Hello and welcome to the EduTalk series hosted by Biotone EduPartner School Program, and massage industry experts. With the growing interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Tonight's expert is Pete Whitridge, who began his massage career in 1988. He teaches his Myofascial Components of Pain workshop nationwide and is a frequent speaker and presenter for AMTA and FSMTA chapter meetings, as well as AMTA National Convention. He's a founder and past president of AFMTE, the Alliance for Massage Therapy Education, and is dedicated to helping establish high standards for massage therapy education. He currently serves on the Probable Cause Committee for the Florida Board of Massage Therapy and is an Accreditation Team Leader for COMTA, the Commission of Massage Therapy Accreditation. Let's listen and learn as Pete discusses therapeutic strategies for surgery, scars, and burns, discussing how to deepen your therapy skills and explore how manual therapies can affect traumatic, surgical, and burn scars. Pete will expand your knowledge about wound repair and the effects of touch on the body, while revealing how scars or burns can change at a cellular level when treated with massage therapy. Thank you again for joining us tonight. We have a lot to get to. Pete has a ton of information to share. And with that, welcome, Pete. Thank you so much for presenting tonight. And I will sign off, leave it to you, and see you on the other side for chats.
All right.
It's all yours.
Thank you so much. And thank you to Biotone for having me. Really appreciate doing this EduTalk, be a part of this series here. One of the things I will do is I will put up my share screen. There will be a tremendous amount of information for you all from a Dropbox. So I want to just welcome you all. Sit back. We've got about 45 minutes or so to run through a whole variety of things. And then, of course, there will be resources for you to reference as we end the program. And you'll get an email with this PowerPoint and this Dropbox here that will have a lot of information. And I will share a little bit of that while we're on the video here. All right. So what I want to do is be sure that we have a little bit of fun. So I hope that you'll put some things into the chat. I'm always interested in doing a little bit of dialogue, not just presenting to you and lecturing to you. I've got some videos, so I hope that will help deepen your anatomy. And like I say, I think it's so helpful to have things in the Dropbox. I live in Fort Pierce, Florida. I've been married to my wife for 42 years. I've been a massage therapist since 1988. I love massage. My whole family is part of massage. I have been a director of education. I've taught at massage schools all around the country and have been a CE provider for quite a long time. I've got a lot of hats. I've worn a lot, done a lot of things. So part of my job here is to make you think about what you're doing with your clients, help you organize your thoughts when you're actually working with somebody who may have had a hip replacement or a knee replacement. I think it's challenging to take your practice to the next level. Since I wear so many hats, I thought I'd show a picture of some of those hats. Next slide. One of the things that I want you to realize is that there is some science to what we're doing here, but there's also like a little bit of art that goes on. So when we say, "Oh, you should do this" or "You should do that," I want to encourage you to also be adaptive, be curious, be creative. It's not just one thing; it's could be many things that we're doing here. Um, One of the things that I have found in my practice is that as my clients get older and more mature, they start to have more scars, more burns, more damage to their tissues, and having the ability to work with that is really an honor. Some of my clients I've seen for 15 or 20 years, and they all of a sudden say, "Oh, I'm going to get a hip replacement. Can you help me?" So I want you to, use this time to kind of think about who you might be working with in your own practice. Danelle was talking with me about her sister who had some pins and plates in her ankle. I'm sure you've got people in your family or even yourself where you've had some kind of surgery, some kind of scar that's in your body. And if you tell me you don't have a scar, I'm going to remind you that you have a belly button. So that is your original scar. I'm kind of a science nerd as well, so I have some slides at the very end from PubMed, things like that, to help you know that there is some evidence regarding scars, but it's very difficult to do a randomized controlled trial. So what I would say to you is we're going to do a lot of case reports. We're actually going to think about, oh, this person's going to have a surgery. Let's keep some track and see how their ranges of motion are, how their sleep is, how their pain is. Um, I think it's always helpful for you to know about burns and scars and wound healing. So I want to kind of spend a little bit of time paying attention to what I call wound repair or tissue repair. We learn this in anatomy. We go through and we briefly talk about tissue repair and cellular repair, but we don't always retain that. And so I just want to kind of give you some ideas as to some of the things that I find important, some important ideas, and then we'll look at a couple of movies as well. Um, so I know that each of you, when you were in massage school, you learned about the stages of wound healing. I love this picture. This is from Bentonville, Arkansas. I went to Crystal Bridges. This was a mural up in the city. Um, I just think that sometimes it's nice to see some beautiful photos and different things through a class. So I'm showing you one that my wife and I saw when we were in Bentonville. Um, Here are the typical stages that we think about when we're talking about wound healing. I was just talking with my yoga teacher about remodeling and how important that is. We're going to just kind of go through these: inflammatory, proliferative, remodeling. Um, this is a big slide. There's a lot going on here. You can see that there are events, there's cellular response, what's happening at the vascular level, whether we have capillaries open or capillaries closed. And here are those names that we just talked about, and then also some time frames. And you'll notice that this is goes through 3 weeks and then to a year. So lots going on here. Collagen is a big thing here, the cytokine bath. So I just want you to have some ideas that there's some science here, and if we can help our clients understand a little bit about what to expect after 5 or 7 days and what to expect after 3 weeks, they can then tune their bodies into, oh, well, this is kind of normal, or this is what's expected. And so I think that that's always helpful. So I've got a little film here. And this is one that will kind of go through these stages in a visual format. And if I can get my pointer to run this. I like this little video. I think it's helpful for you to see this.
In every wound type, the healing process runs through a cascade of phases, which partly overlap in time. The immediate reaction to injury is a contraction of the capillaries to reduce bleeding. Red blood cells and platelets released from damaged blood vessels flow into the wound, aggregate, and produce a plug or clot in the wound. The first step in the inflammatory process is dilatation of the capillaries. Increased permeability of the capillary allows serum and white blood cells to migrate into the wound area. Here, the white blood cells differentiate into different cells, including neutrophils and macrophages. Neutrophils and macrophages are attracted to the damaged cells and bacteria by chemical substances. They become phagocytic and engulf dead tissue and bacteria. Once all the dead tissue is eliminated, the inflammation gradually subsides. During the proliferation phase, the wound is filled with granulation tissue. Granulation tissue consists of newly formed capillaries and connective tissue. The formation of new capillaries, angiogenesis, ensures that nutrients are supplied for granulation tissue formation and is essential for wound healing. Fibroblasts are the predominant cells in the proliferation phase. They migrate into the wound site from the surrounding tissue and start to multiply. In the last part of the proliferation phase, the wound is made smaller by wound contraction. Wound contraction is brought about by specialized fibroblasts with contractile properties called myofibroblasts. When the granulation tissue filling the wound is almost at level with the surrounding skin, re-epithelialization starts. The epithelial cells change shape to facilitate locomotion and crawl across the wound bed to cover it. Migration stops as soon as cells regain contact. The cells change back to their normal appearance and reattach themselves to the basement membrane. The wound is closed. The transition from granulation tissue to scar tissue involves reorganization and maturation of collagen fibers to maximize tensile strength. During remodeling, the fibers are orientated along the lines of tension and cross-linked to form a strong wound. Remodeling can take up to 2 years after wounding.
All right. So for me, it's just a wonderful review, right? There's some wonderful words in there. Myofibroblasts are something I learned about with the very first Fascia Congress. So I'm just going to keep moving on here. And there's a couple of things, a couple of places that we want to really get some words out of this. Most of you understand about clotting. I'm going to keep moving on. You can see these inflammatory cytokines, right? TGF beta and IGF growth factors. This is really what we're thinking about when we talk about a cytokine bath. And we learned from COVID, right, that people have cytokine storms from getting a respiratory disease. So I really want you to see that this is a cellular response to the wound, whatever it is, burn, scar, and so we want to know about those. That this is a big aspect. And then, of course, I know in anatomy we learned about cells. I used to teach cells and tissues, and so I really want you to know that these things like neutrophils and eosinophils, these are really important aspects. And sometimes people who we're working with have poor immune response, and and problems with their blood. So I want you to know some of those cell names. Macrophages, monocytes. You'll notice that the cytokine bath is involved with all kinds of activation of tissues. And so I want you to just be aware of that. And then here's a picture of a variety of one of these cells. One of the words I want you to learn as we go through is this thing called angiogenesis. But I'm back at this little picture here just for a moment, right? Neutrophils, macrophages, leukocytes, fibroblasts. And all of you know that when we make protein, we're making collagen, and it's the fibroblasts that create collagen. And this is why the fascia research is so interesting to me, is because this is a cellular process. And I really want you to move into looking at this massage work as cellular work, not just muscle work or nervous system work. It's cellular work. So here's a wonderful picture. I'm not going to spend too much time on here, but it gives you all of these different layers. When you get this PowerPoint, you can kind of look at it and review for yourself. This is well known, the wound repair, tissue repair, regeneration of tissue is well studied, and there are actual very large journals, and I get some of the articles and notifications on wound repair. There's all kinds of things that I think would be very interesting to some of you as you dive deeper into this. So here's that word angiogenesis. Angio has to do with capillary beds, just like neurogenesis would have to do with building nerves. So I think it's helpful for you to have this word in your back pocket when you're talking to your clients and they've had a hip replacement or a knee replacement. You want to talk to them about how their body naturally, without any kind of concept or thought from them, begins to create new blood cells and nervous system. This process of wound repair is automatic. Again, here's some more growth factors. I think it's really helpful for you to just get a sense of some of this process. I'm not going to spend too much time on these. But one thing I do want you to see here, when the rate of collagen synthesis, right, the creation of collagen is equal to the regulation of the degradation, we have collagen homeostasis. And that's where we then begin to think in terms of the system of going into epithelialization. All right, so I wanted to show you a little bit of a video that gives you an idea of some of the collagen, right? The fibroblasts creating that. And this remodeling video is actually kind of from a company that's quite interesting. And I think that you'll find this is at a kind of almost a molecular level.
The human body is formed from a single cell that divides into trillions of cells, which make up the unique organs of our bodies. All cells in the human body carry the same genetic material. The only way they know how to interact, behave, and form the organs is because of the context that surrounds them. This context is called the extracellular matrix. The extracellular matrix is a dynamic three-dimensional network that provides stability, signaling, and structural support to the organs. The main type of proteins in the extracellular matrix is collagens. Several different types of collagen exist. One example is type 1 collagen that creates fibers and provides strength and support to the organs. Another example is type 4 collagen that is found below the cells. Type 4 collagen forms a structure that helps maintain the barrier between tissue compartments and work as the first line of defense. It interacts with other proteins and thereby enables signaling to the cells. The collagens are different in all organs of the human body. This means that the collagens of the heart are different from the collagens of the liver and lungs. In the lungs, for example, the alveoli membrane is mainly composed of type 4 collagen, which helps the exchange of oxygen into the blood. During development of chronic diseases such as lung fibrosis, the collagens in the interstitial matrix expand. The tissue becomes stiff, leading to a decreased lung function that can be life-threatening for the patient. The change in the collagens is seen not only in lung diseases, but in most chronic diseases, such as cancer and cardiovascular diseases. The common denominator of all chronic diseases is severe tissue damage resulting in cell death and changes in collagen composition. Inflammatory cells migrate to the site of damage, secrete proteases, and consequently break down the collagen fibers, releasing collagen fragments into the environment. Fibroblasts are then activated to build large, complex collagen fibers. To form the fibers, the fibroblasts secrete collagen proteins. During this process, end fragments are cleaved off to enable attachment of the collagen proteins to each other. Just like building blocks, the proteins come together to produce the strong fibers. The cleaved-off fragments are then released into the environment where they attract more inflammatory cells. This maintains the vicious circle of build-up and breakdown of collagens that fuel the chronic diseases. Both the build-up and breakdown collagen fragments are released into the blood, where they circulate together with blood cells and can be used as targets for blood-based biomarkers. Collagens are structured as a triple helix, where different domains of the same collagen provide unique information. Some fragments reflect tissue buildup, some reflect tissue breakdown, and others are signaling fragments. In patients with chronic diseases, there is an increase in tissue buildup, tissue breakdown, and signaling fragments, while in healthy subjects, there is a finely tuned balance of the tissue. The levels of tissue remodeling vary from the individual chronic diseases, both in terms of tissue buildup and tissue breakdown, as well as the types of collagens involved. Nordic Bioscience protein fingerprint technology is the only technology that differentiates tissue buildup from tissue breakdown by quantifying different fragments from the same collagen. This is essential to understand and treat all chronic diseases. Learn more.
All right. So one of the reasons I wanted you to see that is I just want you to get a sense that many people who come to us who've had some kind of surgery are in a constant inflammatory response. And so part of our job is to help move the lymphatics, to help calm the systems, to help the person sleep better, and to reduce their pain. I think if I could just challenge you all just a little bit, think cellularly, think about the physiology that you're addressing. All right, and just going to move on from this. I think it'll be interesting for you to kind of see a few scars, think about the scars. This is a sunset where I live in Fort Pierce. I love my town on the east coast of Florida. Okay, so let's see a couple of surgical, traumatic. I'm not going to show you any burn scars because they're kind of traumatic for people to see, but I will give you some kind of animations for that. Here's a gentleman who's had an open heart surgery. He came in for a class. You can see that these are some drain holes. It was just a couple of weeks after this heart surgery, but I think it's a very interesting scar picture. And then this is a gentleman who was in his 70s and had an appendectomy when he was about 13 years old. So good example of 3 different types of scars: heart, drain holes, big scar from old surgery. Here's a traumatic scar that you can see. This was a person who was in a Jeep rollover. When I teach a scar class, usually people come up with their very unusual scar and they give me their picture. So if any of you feel like you want to give me a picture of your scar, that would be helpful. Here's a traumatic scar. This is a motorcycle accident. You can see that he's had some surgery here. You can also see that he's had some traumatic scar from losing the skin and the tissue below the skin. Here's someone who was actually a cutter, tried to kill themselves. I would say this is a kind of a hypertrophic scar. This was usually made by some kind of sharp instrument. Um, uh, this is not a client of mine, but somebody who was a colleague's client. Here's a dramatic scar. This is one that I pulled off of the internet. It's not something I've worked on, but I would call this a keloid scar, right? Where we actually see that this is a young person who had some kind of abdominal surgery as a child, and some of that scarring has really come out into his systems. Could we work on this scar? Of course we can. Are we going to change the scar and make it less dramatic? Potentially. All right. This is a picture from my mom's, where my mom lives up in DeLand. You can see it says we have infinite clearance, be here now, one way is love. So I think that burns are an important aspect of working with people. Some of you have probably had some kind of sunburn or a steam burn. It's important to pay attention to the skin. Many people find that lavender or manuka honey may be very helpful for reducing some of the pain with that. Usually we're just dealing with the outer covers. Second degree, notice that there are two, they call it a partial and a full. Usually we'd see some kind of blisters. Many times this will heal quite nicely without any kind of grafting. Very rare to have a scar from a second degree partial. This one, many times, has problems with the external tissue, second degree full. I'm not going to spend too much time on this because I want to get you to see some of the techniques. And then third degree, I used to be an EMT, worked in a hospital. I've seen a number of third degree burns, and for many people, it does not hurt. The burn does not hurt. It's the other parts of their bodies that hurt. But I can tell you that you can see well down into the tissues, and sometimes people get electrocuted. Please note that just because someone has had a third degree burn doesn't mean that they shouldn't have some attention paid to this. One of the people who's inspired me the most to do scar work was dragged by a bus for 12 blocks in Gainesville, Florida, and she had her whole leg, tremendous amount of burns and scars, and you know, has gotten a lot of help and support from that. Okay, sometimes we see skin grafts. This is a good example of what a skin graft is. You'll notice that there's holes that are made here that then makes the epithelial tissue grow between this. When you have somebody who has some kind of graft, find out where the graft came from. I'm a very hairy person, so it would be very hard for them to find skin that doesn't have hair on it. So just be aware that just because they have a skin graft, they're also going to have some other place on them that may also need some work. Okay. You'll notice that one of the things they talked about in the skin wound repair was uh, pressures and alignment to ranges of motion. I think it will be really helpful for all of you to help your clients be sure that they're actively moving their tissues in ranges of motion that they use every day. That is going to be one of the best things that you can do at the cellular level. For instance, if a mom has had a C-section and she is struggling after the baby has come into the world, and a couple of months later, she's kind of gotten her wits about her and is able to do some movements and help herself. Regular movement of the scar, as well as regular movement into extension with both the legs or the trunk, can be tremendous help for helping the remodeling of the tissues. I love this picture. I think it's um, a Photoshop, but I can't be sure. What I always say is you'll probably find yourself in the funniest of places when you work on scars. So keep aware, think about where you are. Sometimes you're going to be working with somebody and you don't quite had never expected to be there. Here's a good example of um, a patella fracture and repair. You can see here that there are some wires and some screws. You can see there's some staples here. All of these areas in this knee will actually be eligible for some work from us. This happens to be my mom's knee. You can see it from the side, and you can see these screws, you can see the wires. My mom's 85 years old. She's doing great. You can see the staples out here. She has a very good range of motion, very little trouble with this knee. Here is a good example of a scar that's curving. This is an elbow. And many times when we're working with someone, you'll notice that where the incision starts might be a little thicker, where the insertion ends, that may be a little thicker. We want to pay attention to all aspects of the scar. And you'll notice it's made in a curve. I'm going to encourage you to do a lot of curving and moving of the tissue in an S or J or C curve. All right. So I think one of the most important aspects of what we're going to do is I want you to help people have a positive experience around touching their scars. I think that your skill and ability and your confidence of just helping people by being curious about their scars will help them feel less uh, um, self-conscious about their scars. If you've ever been to a Phoenix Society event where everyone who's at the event has had some kind of burn or traumatic scar, you can just gain appreciation for, how people feel about what they look like. I think it's also very important as a therapist that clients work on their own scars. I think that so many times people are afraid to touch their scars or it feels a little weird to them. So that will be one of my goals with you all. And then I'm a gentle bear, right? I'm a man. I work a lot with athletes. I work with all kinds of people, but the people I love to work with the most are people that I have to be gentle with. And so that's why I do and focus on myofascial therapies. I work slowly. I work very, very gently. Okay. Here's a wonderful picture. This is from St. Augustine, Florida. This is one of my dear friends, Kurt Pullman. He took this as a time-lapse photo. I think he's a beautiful photographer, and I just thought that that would be a nice kind of way to set your eyes off of some text for a little bit. So I think assessing the tissue is going to be one of the next pieces that I want to make contact with. So here's a little video, and this one it's pretty quick, but you get the idea what we're thinking about.
Yeah. You have to start in the middle?
No.
Okay. I just want you to see, like, that's just my style, right? Like, I start in the middle because I'm lengthening. You could go from one end to the other end. It's being consistent as to what you're doing so you can remember what you haven't done.
Mm-hmm.
Yeah, I'm pulling pretty good, aren't I? Okay. Can you do some plantar and dorsiflexion with your foot? Adding motion, right? I can feel the sliding in the quadriceps. Like if I had an ultrasound, we'd see those sliding surfaces.
Right.
So as a visual, that's one of the nicest visuals you can now start to use with your people. Sliding surface.
I noticed you didn't put any type of lubricant on it either.
I did just a hair, just a teeny bit. Yeah. And now, right up here, it felt like it kind of went through the quadriceps tendon a little bit and kind of getting more into the meat.
Yeah.
Okay, so that was the place I got most interested in.
Yeah.
So I'm gonna lift it. Good. You happy with that pressure?
Yeah.
So can you do inversion, eversion? Good.
Do you need another pull for your head? Are you okay?
Good. You're so good at that, right? Most people go really fast when they do inversion, eversion. Right? They're just like gross motor movers. Good. Rest. See how something just, yeah, see what just happened though? Like my hand got warm.
Yeah.
So I'm verbalizing what I'm experiencing so that you get the sense like it could get cold, but it got warm.
Yeah, for the movement.
Yeah. Okay. And then the S curve, it's just, I couldn't quite, the lighting where we were sitting wasn't quite what I wanted you to see. See what I mean when I say S curve?
Mm-hmm.
Now plantar and dorsiflexion again. Good. And then go plantar dorsi now. See how you're pulling where I am now? Inversion, well, eversion was doing it too, but the plantar and dorsi is a lot.
More.
And then rest. And so I could go one direction or the other. Seems easier this way.
Yeah. Okay.
Okay, so then I would be like, oh, we gotta go back this way then. And again, when we're working with somebody's scar, it's kind of interesting to laugh and talk about play. And so I'm also going to remind you that Milton Traeger, Dr. Milton Traeger taught us something, right? Rocking has a role in our work. So the last piece I would pay attention to on any scar is at the very ends of the scars. So that's sensitive?
Not as bad down, but up.
Like
Up.
that. Oh, okay. Right, where that initial cut was. So sometimes there's a little nerve or a little place in the muscle that's quite sensitive.
Feel the stitches, the knotted at the top underneath on the top.
Okay.
Okay.
Yeah, so then I'm gonna push towards Phyllis. Just so I can feel the tissue, right? Yeah, there's definitely something there.
Yeah.
So I think in my job, my role is to try to create some inflammation. Not inflammation that's going to be so detrimental that the person will be knocked down, but to create some inflammation. Because then the body's going to naturally bring cytokines into the area, TGF betas and all kinds of growth factors, and the mast cells will come into the area and clean up some of the extra collagen. Do you like that direction?
Yeah.
Yeah. Okay. Is everybody clear what I did? So if I were to, say lengthen, then we could come and broaden. We can lift and we can spin. And in the midst of all that, we're going to play with some motion. Now, what do you do if you don't have a scar?
Scar tissue.
Look at Heather, what do you do if you don't have a scar? Just keep working on people. Right? Okay. Now, do you have any earrings? Again.
All right. So you get the idea and some of the principles that I'm thinking about. I just wanted you to see a couple more scars and the effect. This is a very superficial scar. Many people have dermal moles or precancerous lesions taken off. So we just did a little bit of what I was doing with this person. And the next slide, you can see how much redness and raising up of the tissue have happened here. This is a gentleman who had a very deep cyst. So we were lengthening this, we were spreading this, we were really helping him because he felt like it was affecting his shoulders. This is a man who was very tall as well. So he really enjoyed getting this work because it helped him kind of elongate his spine. You can see a good example of the S curve, same person, just using my hands and warming the tissue. And then, of course, I lifted it. And when I lifted this scar, when I lifted this cyst area, he was like, oh, that feels so good. I wish somebody had done that 10 years ago. So I really want you to see I'm not using hard pressure. I'm being very gentle. I'm only going to where the tissue moves to, and then I'm stopping. But I'm holding the tissue and I'm allowing the cells to secrete their hyaluronic acid. I'm allowing the sliding surface to begin sliding. So here's a little one with a stitch that was there. And again, I'm just lifting the tissue. I feel like I learned this from Dr. Gambarteau at many of the fascia congresses. He's always lifting the tissue instead of compressing the tissue. So I think this is something I would credit to Jean-Claude Gambarteau. It's a young lady who had a wrist surgery. The wrist, the scar was very indented. I lengthened the scar. I spread the scar. You can also notice that she actually has a scar here that's a kind of a white scar from tattooing. Very unusual. So this was the indented scar. Here's what it looked like after about 5 or 6 minutes of work. I want you all to know that you can affect scars with just a very short amount of time. Dosage is really important. This is not something you're going to do for the first time with somebody for 10 or 15 minutes. You're going to touch the scar, you're going to assess the scar, and then you're going to move on. Okay, this is not something we spend a lot of time with. So, like I said, you're going to find yourself in a lot of funny places, and a belly button scar, right, where actually somebody's had maybe a gallbladder taken out, and they say, "Oh, well, we'll just do it through the belly button. It's so much easier." Well, I can tell you that going through that belly button is very sensitive, and sometimes people have a tremendous inflammatory response from that. So, you'll find somebody yourself on the belly button of somebody, or maybe you'll work with somebody who's had some kind of surgical intervention, whether they've had a breast reduction, mastectomy, some kind of knee replacement. All of these scars are going to give you some challenges and give you an opportunity to expand your practice. All of you should be using some kind of pain rating scale. I happen to be a big fan of the DVPRS, which is from the Department of Defense. It's used thousands of times a day. It's a validated instrument. It has 5 very specific questions. This is the first question about pain. This is the second side of this. 4 questions: activity, sleep, mood, and stress. These are really the outcomes that we are looking for when we think about massage therapy. When I was involved with the studies for the Massage Foundation and the Samueli Institute to start having massage on the bases and working with the DoD and in the VA, this is what I was introduced to. This should be at every one of your offices. You should have this laminated, be able to have people use this so that you can keep track of them. Remember, I talked about doing case studies. I think this would be one of the best things you could do to help your clients. Then there are all kinds of scales, and I'm not going to go through all of these scales. There's an article about these scales, but I can tell you that when I work with somebody and I have them coming into me and they are actually going to be in recovery, I will fill this out and I will keep track. And I don't use all of the individual scales, but I want you to see that there are all kinds of ways for us to think about what's happening here. Is it lighter? Is it darker? How many scars there are? Does the person have some kind of dysfunctions? Um, the more data we can collect, the more information we can get from the client, the better we're going to be as we start to think about helping physicians understand the importance of scar work. No one is ever told anything about how to work with their scars on release. People go to rehabilitation and they're constantly afraid that they're going to break open their scars. I'm here to tell you that they will not. We are going to work with people when it's safe, 6 to 8 weeks after, when the scar is fully healed, and we are going to help them embody themselves. This is actually a picture of a scar adherometer meter that you can create. It helps you put your bullseye onto the scar, and then you can move it one direction or another for your assessments and see if there's one direction that it is better movement than another. And then, of course, sometimes when I think about this, which scar scale would I use? I'm going to use a scar scale that's going to be simple. I'm going to use the DBPRS, and I'm going to help my clients be able to talk to their physicians. I have a couple of clients who've had recent knee replacements. They had a tremendous amount of pain afterwards. They had inflammation. They had me come over, and all I did with them was a little lymphatic work, moving the tissues. And so all I'm saying to you is, we need people to understand that what we are doing is valuable touch. I have a few guiding principles. I think we need to teach people how to breathe. We need to be in partnership. Movement is really important. Thinking in terms of the global body movements. I'm going to work under the pain threshold, and I work very slowly. I think you saw me working slowly. There's much more we can talk about, but I've gotten myself to about 48 minutes here. I think that there is a whole Dropbox here. My phone number is here. I've got my email. When you get this from Danelle and Biotone, you can click on this link. I've got a tremendous number of things in the Dropbox. I'll just give you an idea of what that might look like over here. And let's see. I'll show you someplace else. Here we go. So when you get this, there's some movies, there's whole articles on scars, there's some reading material. Don't be afraid of the Dropbox. You don't have to sign in, you don't have to join up, but you can see that there's all kinds of articles that I've got here, all kinds of things in the handouts. So I think we can ask some questions and kind of have a little Q&A. Can you please explain more about the bullseye graphic? Yes. So this adherometer is designed to be placed specifically on the scar, in the center of the scar. It's made with a clear laminated thing that you may get at a office supply. And then what you would do is you would use it in the direction superior, inferior, medial, lateral. And then as you do that, you can keep track of what those millimeter circles are. Even when you work on your own skin, right, you can measure those millimeters of movement. And so what we were thinking about is if you had a very broad scar, there might be some places that don't even move at all, and then other places on the other side that move a lot. And then you can have a comparison. I think this is an important aspect of what we're doing here is, are we making progress? Is the person feeling differently? And then, of course, how about their activities? What about their sleep? What about their mood? The DVRS is such a great tool for outcomes. If we could do nothing as massage therapists but help people sleep better, what a great job we're doing. Then, if we can increase their range of motion, wow, right? And then, right, what if we actually help them touch their own scars and work on their own scars? What a beautiful thing that could be. All right.
Thank you.
Uh,
Thank you, Pia. I'd like to address Tricia in the follow-up email tomorrow. And Pete, would you mind closing down your screen share, please?
Sure, yes, I was just going to do that. There you go.
Okay. Thank you. In the follow-up, and to those of you that are just joining EduTalks today for the first time, tomorrow you'll receive a follow-up email. It will include the link to tonight's presentation. It will include a copy of the PowerPoint, and as Pete showed you, the articles as handouts. It will also include his contact information. And yes, he's located in Fort Pierce, Florida, if I may. And Tricia, if you need that information immediately tonight, just feel free to chat that and we'll get it to you. We have time for more questions and would love to hear from you or comments. Again, Pete, with the pins or screws or whatever, it doesn't matter how long they've been in there, you can still work on that, and it's still part of the healing process for the scar. You can still work on that area.
Yeah, so it's such a great question that everybody asks. Oh, I've had this 20-year-old scar, and what I would say to everyone, right? Every scar goes through all the layers. So whether we've gone and put screws in the bones or we've taken something just off of the skin, we are affecting the connective tissue of the whole body. And so screws and plates, if they're sitting beautifully, we can assess that tissue and it's going to just be movable and helpful and moving along. But I can tell you that a little bit of lymphatic work and working where those actual pins or scars screws are has been a tremendous eye opener for clients. I have a young man that I work with. He's young, he's 50, and he is so grateful to have found me because he was not able to move his foot because he had his ankle plate put in. And he worked hard, he cleans all these different things, and so much of what his range of motion has done is because we literally just touched his scars, touched those screws, and then moved the lymphatics and had him start to do personal range of motion. Now he soaks his feed, he takes care of himself, he sleeps better. Whatever age the scar is, I'm so interested. I'm always like, sometimes I call myself a scar dog, right? Like, can you tell me your story? Can you really help me figure out what's going on there?
Joanna is asking, how much time would you devote to the scar in each session?
It's a great question, Joanna. What I would say to you is each scar is going to get maybe 6 or 7 minutes once we've introduced ourselves to the scar, and then I'm going to move somewhere else to let the tissues flush in fresh oxygen, more fluids, interstitial fluids, and then I'll go back and check it. But sometimes when we're working with a big scar, we can only work a few minutes, right? So I would say less is more. There's a paper that's on the PowerPoint. The dosage was about 1 minute to 2 minutes. I find that that's not quite enough for the person to get used to me working with the scar. but when I say 6 minutes or 7 minutes, it's usually somebody who's been with me before. The first time I touch someone's scar, it might be just a minute so that they're like, oh, okay, that wasn't as bad as I thought. And I have a couple of clients who have kind of little like hole scars, like maybe they got punctured somewhere. And I'd say, oh, I hadn't noticed this before. Can I touch this? And I'll touch it and I'll go, ow, right? Like, oh, I hadn't felt that before, even when I was washing myself. And I'd say, well, so let's just touch it now, and then tonight you touch it again, and then you touch it again. And so what we're doing is we're helping connect the brain and the body again. I think that's something too. Um, yeah, and so Jody, I think one of the things you're asking about is probably the thing I focus on the most is right, the emotional connection, the story, right? And so I think it's so valuable for me to slow down. And if I've got a client that I've known for a long time and they're coming in for a from a hip replacement recovery, we might not have to deal with so much of the emotional issue, but I've got a variety of people who've come into me and we've just doing massages, and then I'll say, well, it seems like you've got a scar here. Can you tell me the story? And all of the memories come back. So to me, I feel like my job is both counselor, observer, and caregiver. So I think scars are part of our story. You can talk to someone who's had a scar from when they were 3 years old and now they're 60 and they tears come in their eyes. I think it's just the greatest part of our work is to pay attention and to offer the space, the quiet space, the listening that helps people feel safe. Um, and so, Jody, to me, the reason I don't just jump in and work on somebody's scar is because it is emotional. That woman I showed the traumatic scar from the Jeep, she's like, you can work on my scar, but it'll make me cry. I said, well, I don't have to work on your scar. It's just up to you. Um, and
Very good.
then and then it looks like Zerilyn asked, right? Um, how long do I work to wait with the surgery? What I say to people is wait till the scar is closed and it's not weeping. That might be a little bit different if it was a family member, or if it was me. Like if I had open heart surgery, I'd be touching it quickly. But most of us aren't going to want to be touching somebody's scars when it's got the stitches in it, when it may be weeping. It just depends on our level of skill and abilities. When my mom had her knee patella thing, I was working on her scar with gloves 3, 5, 7 days afterwards, doing some lymphatics, doing some movement. But my mom's a massage therapist, so um, I want it to be healing. I want it to be healing. And then the question is about oils or lotions for self-care during a session. Um, so, so I'm a big proponent of jojoba oil. I think that jojoba, which is a bean, is very like the skin, like the sebum. There are many, many products out there that are part of the essential oil world, helichrysum, um, things that are cicatricent. So I think those are very helpful. I think that Biotone has an oil that's involved for scars. I'm actually have a bottle that my wife made called Cell Renewal Oil, and it has a variety of things. But the main thing that I love in it is the helichrysum. Immortal is really amazing. And then in the scar world of the Phoenix Society, people are using Manuka honey based things. They're also using things that are very natural. So some people use coconut oil, fractionated coconut oil. Some people use almond oil. Some people use almond oil and a mixture. So, you know, be as natural as you can. And then I would say for all of you, burns really deserve a little bit of lavender. A lot of the studies show that if you've gotten a steam burn, if you throw a little undiluted lavender on there, you will feel much, much better from that, and you'll reduce the inflammation. So that's a interesting piece.
Pete, I have a question regarding the collagen.
Yes.
Uh, because so many products now are including collagen, be it a scoop of this you put in your coffee or in lotions and topical. Does that have any benefit to working with scars using, a topical that has collagen in it?
So I love your question, and I think that this is kind of another one of those marketing pieces. Our body is designed to make collagen. The fibroblasts are part of our body. Enhancing your collagen intake by taking collagen as a powder form or bone broth hasn't really gotten a lot of uh, evidence showing that, oh, yes, we should do this. Although I will tell you that some of the soccer players have really benefited from a good dose of fresh orange juice and 15 milligrams of Knox gelatin. And that was helping them prevent injuries. So there is some evidence for that, but really, truly, adding collagen because you think you need collagen isn't necessarily the right answer. And you see collagen everywhere. My question always is, well, where did that collagen come from? And, how do we know that's clean collagen? One of the best ways you can make collagen is to make bone broths from chickens that you know, or cows that you've met, who were raised on grass and things like that. So over and over again, my brother's a clinical dietitian. He talks to me about collagen all the time. He says, people want to use it, but it's not necessarily going to be adding to their collagen level in their tissues.
Okay, thank you for addressing that. I'm going to mention our upcoming EduTalks, and if you wouldn't mind typing into the chat your contact information again, that was requested earlier.
Oh, sure.
Just your email, your phone number.
Sure.
And I'd like to invite you all to upcoming EduTalks on June 4th, and it's amazing how this year is flying. We have Adrienne Asta with the Massage Therapy Foundation. She'll present Unlocking Relief, the Power of Massage Therapy Research in Managing Headaches. And as well as the EduTalk series for massage, we have the EduTalk Diabetes series. And on June 11th, Michaela Dollinger will present on simple daily habits to aid remission of type 2 diabetes. Then June 18th, Michael Morgan will present craniosacral therapy and applications for Alzheimer's and dementia. So we have a great June lineup and a wonderful, informative EduTalk closing out May. Thank you so much, Pete. And thank you for adding your contact information there. Where are we going to see you next? Anything in closing that you'd like to add?
So next, this is kind of an off year in Florida. So I've got a couple of things coming up in Florida next weekend, and then I'm headed to California. So probably the first time I would be available would be in Oak Ridge, Tennessee in October 5th and 6th. And then also in Kalamazoo, Michigan at the Institute for Massage Education. My schedule is up on my Whitridge Wellness. And then I will also be teaching for New York AMTA. And then I'll have my full schedule for Florida and then, in renewal times. So look at the schedule. I'm kind of taking the cruise right now so that I'm recovering from last year's renewal time. So I'd say September, October will be the first most people get to see me.
All right. Well, great. Again, everyone, thank you for joining us. Watch your inbox. If you do not see the follow-up in your inbox, please check your spam. Additionally, the Biotone catalog, both the hard copy and online, includes the upcoming quarterly schedules for EduTalks, both EduTalks for massage and the EduTalk Diabetes series. So take a peek at that and see what we've got lined up. Again, thank you. Watch your inbox. Pete, big hug to you. Thank you so much for this informative. And I'll just quickly mention to the participants, Jody and Sandy Fritz that have been on the chats tonight have both presented for EduTalks. And you can not only find Pete's EduTalk there tomorrow on recording and on YouTube, but Jody and Sandy Fritz have previously presented, and they are also in the archive library on biotone.com under the EduTalk tab. Thank you so much, everyone. Be safe, and we'll see you next time. Have a relaxing rest of your summer, Pete.
Thank you. Thank you so much. So glad to be here. Thank you to Biotone.
Thank you. Take care, everyone.